Hello, everybody. Warm greetings to each and every one of you who's joined us from various parts of the world for the sixth day of the biggest implantology event of 2020. Yes, ladies and gentlemen, I'm talking about the world's first virtual implant expo organized by DentistChannel.Online. Ladies and gentlemen, this presentation was actually scheduled with Dr. Victoria. Unfortunately, due to a technical glitch, I regret to inform you that Dr. Victoria would not be joining us this evening. However, we have something more special for you in store, and that is a beautiful lecture on the topic complications and its solutions in implant dentistry. Dr. Souheil Hussaini, a wonderful personality and a person who's been practicing since the last 27 years, would be presenting. It's a recorded lecture. I request you to watch the lecture and give us all your questions, and I'm sure it would be a wonderful presentation for you. So, ladies and gentlemen, presenting to you a lecture on the topic complications and its solutions in implant dentistry.
I appreciate your presentation. Thank you very much. I'll just go on the last few slides of last week. If we look at implant dentistry as a building, which has 7 stories, and every story can be designed differently in your practices. However, each room in every story has an importance, and it has to be followed with skills, knowledge, and experience in every room, because each room has a value, and we should look at this whole picture of every step that we do, for whether it's a block graft, whether it's particulate graft, whether it's an open sinus lift, internal sinus lift, immediate extraction implant. All these rooms that we discuss, each one have to be clearly understood, and every step should be known, how you do every of that step. We discussed about if there's a suturing error, the concept of time is an issue when you are receiving a complaint from a patient. When was it happening? And it's very important to learn to appreciate the power of when. Same thing with the position of a wrongly placed implant, because if you know when this has happened, it makes a big decision making. And if you're strong in every department, you know, for example, in this scenario, this was not a placement problem. This was an osteotomy issue. And accordingly, you make a decision. Same thing with this case, you know, the bone was harder, so they broke the screw. We discussed about this. My point is, I'm just going back for the ones who, to refresh your memories. Finally, we've come up to this 7-story building, that each building is very important. And every room in every floor in this building has to be recognized at the early stage of implant therapy, because negligence to any step will compromise the case. And what are we doing in this program, this 1-year program? We are trying to identify the frequencies of the complications and the risk factors, and also how to avoid those complications. We discussed about this lady who just needed a cervical erosion filling, but she landed up receiving a dental implant and a root canal and a new crown for no reason, because of the diagnosis was not well documented. Now we start today's session with an understanding of the difference between an event and a process. What we are suggesting to this class members, that we will take you from an event form of doing implants, that the patient comes, you place the implants, the patient goes. If they have a problem, they come back, they tell you the problem, and then you solve the problem, you make a decision, you're motivated for these people, you have a calendar today. Your receptionist has told you that we have an issue today. Mr. Jones has pain on her implant, and his implant, or Mrs. Jackson has broken a screw or something. You come to the calendar, you come to the appointment, you have a challenge to fix it, and you fix it and you go ahead. This is what is an event. However, what we are discussing is a process. A process, it's not, you don't make decisions on the spot. You develop a strategy that automatically will care for all the possible problems that can happen. It matures you and your patients to another level that they're always being cared for, and it's consistent. You have a, it's not something that only happens based on the calendar and based on your secretary informing you that today we have a complication. Consistently, you know how to deal with any problem that can happen because there's a protocol. Of course, it has its challenges, but it changes people from being just solving that problem for the day, or you are always aware of the possible problems that could happen and you're prepared for it. And of course, it's more difficult to be a part of a process and part of an event. What are we mentioning here is normally a patient comes, step one, you do the treatment. If they call that they have a complication, that becomes second step. You identify the solution for that complication, you solve it, the patient goes back to normal life. That's what normally happens in the general protocol of most of us. And that's what we are suggesting to change. What we are suggesting to change is we are predicting the complications before the treatment starts. How? Because we have a classification of complexity where the articles that was sent to you last week, again, it will be sent again for the new ones who are part of the program. So we are classifying the complexity before we do the treatment. We are identifying the step in your unfollowed protocol because we are following what happened because we're documenting everything. So when a complication comes, we go back and see because of that step was not followed and that caused this complication, and accordingly we go back to the protocol and we update the steps, okay? And then we document and maintain the treatment, that patient. So we are emphasizing on predicting the complications and emphasizing on the maintenance of the treatment. We cannot let the patients go, at least not to be seen once a year. And the advertisement that we have Facebook, Facebook, and we have different social media, I have no problem with them. But my strategy is, beside those, we have our phone call to these patients and the WhatsApp if we need to inform them about a document or a picture or a video. So we are following with the patient face to face. It's not just a social media that they have to look at advertisements. So let us start the steps. So we are simplifying predicting complications in 3 steps. First, we have to write the steps of the procedure that we want to do. Any procedure we plan doing, we have to know every step in that procedure. And then we will learn how to classify the complexity of that procedure. Then we list the things that can go wrong. And then we use our inquiry skills for every step, how to look at the case from analytical point of view, which is inquiry skills. Now, what is writing the steps was already mentioned, and we can show it again. The complexity classification is a very simple classification that we will all learn from next week. And the reason for that is we all know that we need a universal language when it comes to complication. When it comes to even implant treatment, we need a universal language. If you look at the concept of universal language, we know the advantages of having a universal language. The same thing applies if we are going to treat patients and we're going to treat complications. So if we have a universal language and we're suggesting that for classifying complications, then it's much easier because of the advantages that a universal language has, how to deal with different treatment modalities. And again, I will ask Ruben to provide the articles that for the newcomers, that by, for example, if you want to place a couple of implants for this patient, for you to communicate that to your staff, to your nurses, to the insurance, to the others, you will require a paragraph or a page or 2 pages to explain what you're going to do. Imagine, just imagine, by just writing this on the patient's file, and if this is the universal language of how we classified the scenario, how many implants on which side, and everything is inclusive. You just have to know this language for you to be able to inform whoever needs to be known, whether it's the other referring doctor or yourself or your staff. Just by simply putting few alphabets, you can have a universal language between you and yourself. I think the steps that we mentioned, when you look at them, you might say, wow, that's too many steps. What is going on? But if you look into the simplicity that is made, it reminds you of a driving test. I looked at a handbook of a driving for you to test yourself on driving. The book is 138 pages, how to drive on the street. I'm sure all of us, when we are driving, we don't read that book every day. We know how to drive, but we know if I don't put that gear on that thing without pressing the clutch, or if I don't do that, or if I miss that step, I will make an accident. So we are actually not saying that all these steps will be looked upon every time you do every step. Automatically, you will follow them. The same way you drive. For example, you take a panoramic x-ray, you do intraoral examination, you do bone sounding, you take photographs, and you take impression. That's all you need to do on the first visit. Same thing when you're doing the surgery. All the steps are written. It's not that because we are writing all the steps, it becomes more difficult. It's the reverse. You just read them once, apply them a few times in order, and that's it. That's how that's why it's easier to follow. Now I'm going to take you to an incident that happened last Wednesday, just to because I'm here in Canada and my clinic is in Dubai. I can't go back, so I'm solving the complications of the clinic back in Dubai by consulting with my staff. Let's listen to this audio.
And as you suggested, I irrigated the area. There wasn't any object blocking that area, and in fact what was bothering him was the rim of implant itself, because the gum got a little bit receded in that area, and now he's feeling the sharp edges of implant itself. So I wanted to see, is there anything we can do, because already there is half a screw inside, we cannot place any healing, but you know, anything that we can fabricate maybe ourselves just to place on top of it, so he won't feel with his tongue the rim of implant. Kindly advise. Thank you.
So as you can see, there is a crown missing. There is a broken screw, which is much deeper than the normal space that should be there. Okay, that means one of our colleagues tried to remove the broken screw, but again, it's a complication. And on top of that, the patient is complaining now, the sharpness of the implant is bothering the patient. And if this gingiva was supposed to be 3 millimeter above the bone level, then this would have not happened. So we have two issues. We have a biological issue, which is bone resorption, and we have a mechanical issue. Now, for that, I think it's best if I take you through the case and let us see how this case started. And maybe that way we can understand why this methodology that we are suggesting is a better solution. Now let's look at some diagnosis photographs. Okay, this is 2015. Every photograph is documented. And we have, as we said, we have steps when the patient comes for diagnosis. We have diagnosis photographs. First, the patient takes a panoramic, and then we do the intraoral examination. And then we take photographs, and then we take an alginate impression. That's the 4 steps as we discussed. So we are documenting the steps for evaluating or for diagnosis. This is the area of concern. This is the opposite right side. This is the patient-centric occlusion maximum intercuspation. You can see the crossbite. All right. Let us look at some radiographs so you understand the problem. So the patient at the first point of time, I mean, at the first earliest complaint is on the right maxillary area. He has other issues which will be solved eventually, but the first thing, this bridge is bothering him, the food is trapping, there is a mobility, there is a smell. So this is the area of concern. And the treatment plan was to extract this teeth and to place 2 implants for this patient. As we said, we will follow the protocol. Every procedure has a folder. Every folder has a documentation, the time of the surgery, even room temperature, the date is already in the photographs. The extraction is done. We are trying to avoid preparing the bone in a way that might lead us to place the implant buccally. So expansions are used versus drilling. The implant is 3.7 by 13 is placed. And because of the buccal concavity, we are thinking maybe some bone augmentation is required. If you draw a line from the center of the tooth to the other side, you know we are on the functional cusp. We are not placing this buccally. And we're looking at the gingiva. We are placing the second implant because of the fact we don't have 7 millimeters because we wanted to keep 1.5 from the last tooth as a distance and 3 millimeter between the implants. We chose to use a 3 millimeter, 3.2 actually, but the body is 3. The neck is 3.2 millimeter. Implant was placed. And this is the position. This is the bone graft. As you can see, the bone graft is done. The area sutured. Okay? And we can know how long it took us. So we can kind of keep in mind the dryness of the area, because if we started at 154 and we finished at 240, it's within, we try to keep it in 45 minutes as much as possible, because that's the minimum amount of postoperative trauma. I'm not discussing the procedure now. I just want you to pay attention to, because of the concept of predicting, everything is documented and we are following the protocol. When we come to the time that we want to decide on the solving this problem, which is not a small issue. This came last Wednesday to me. This is not an easy solution, but because we are following a protocol, it becomes suddenly easy. This is a time for uncovery. As you can see, one of the implants is 66, which is ready for uncovery. The second one is 44, which is not ready for uncovery. So either we have to postpone the case, check the vitamin D level, place a healing abutment out of occlusion and wait, or we have to make something called progressive loading, which again, you will receive a link for the ones who are part of the program to see what is progressive loading by Carl Misch. So we are doing the uncovery, and we are deciding that the occlusion, these implants cannot be loaded immediately. The impression is taken for progressive loading technique, and that's the, now slowly your eyes will be, you'll see what is, slowly you'll understand that what went wrong, why we have these problems. Okay, these are the screw retained crowns that we will place for this patient. And okay, I think you are able to see the problem. Okay, there are two issues are very important here that you can easily identify. One is there is a frenal attachment here, and one that depression, that means the bone graft did not take, and that means that if there is no support for the soft tissue, eventually we know the bone graft is going to go. The non-touching part is part of our protocol for progressive loading, but this part is one issue. The second issue was the patient was in crossbite in the previous photograph. We tried to correct the crossbite. So now, because of our knowledge of what did we do wrong is become apparent. I'll show you also the radiographs, so it's easier for you to understand the steps clearly. So this is how the patient presented. This is the expansion, placement of the implant, avoiding the sinus. This is the implant in place. As you can see, the implant is placed at the bone level. And we are doing other implants, but still the bone is kept at the same level. As restoration is taking place, the bone resorption is happening in between, but because of the cementum, the bone is still there on the other two sides. Only in between, the bone is going away. The restoration is showing that still is there. So the bone is not consistently staying in that area, and that was not paid attention to. So if you can see, the restoration is removed to clean the area and to do some augmentation. So now let us go back to the chief complaint or the complication. Look at the case and look at the position of the implant. Now, the reason why we have all this information is because we did not miss the steps. We took photographs at the time of diagnosis. That was a good thing. And that's why we can discuss this case and we can see that depression was there from day one, and we didn't pay attention to that depression. The radiography was done, all the steps, so we know the bone level, and we can see that the issue is not only the bone. The part which we missed was during the uncovery, nobody noticed the depression of the soft tissue and a thin biotype, and soft tissue augmentation was not done. And because that was not done, there was no support for the bone to feel enough nourishment, even if we did bone grafting. So the bone grafting, without sufficient soft tissue coverage, we could have easily at this stage, when I say power of when, at the uncovery stage, soft tissue graft should have been done. We know how to do a soft tissue graft. So this is what is identified now to be the problem. At the time of impression, occlusion was not very much paid attention to. That if he is in a crossbite and you're putting the restoration in a class 1, you are causing a lot of stress on the 3.2 millimeter diameter implant. So that implant, after we did the proper crown, of course we changed those 2 crowns after the ISQ value became higher. Because of that, the screw broke. So the next crown which that tooth is going to have will be, we have to pay attention to the contacts on lateral excursions in a way that it will not break. So by notifying these 2 things, now we know the solution for such a complicated case, what it is going to be. And we have the steps for any procedure. You want guided bone regeneration, we know all the steps. And if something we miss, we can go back and check the photographs, check the steps that we did, and see why these complications have happened. And this applies to any procedure. If you're doing free gingival graft, if we are doing anything, we know the steps and we stick to the steps and we identify what went wrong and we go and correct. So for us to solve this problem is we will remove the broken screw by using a reverse torque kits that is available, and then we will let me go back to the screen. So the first step is to remove the broken screw using a reverse torque kits that is available. And obviously the reason why this went in when the colleague tried to remove it was the first thing we normally suggest is to use a scaler and keep it there for sometimes 7-8 minutes on the center of the broken screw, and go anti-clockwise. Move your hand anti-clockwise without damaging the walls. Probably that part, the anti-clockwise, was not done, and the scaler was actually pushing it in. Anyway, we can remove this screw by using the, as I said, the kit is available. After that, we go to the pallet. We use a pedicle flap, bringing the soft tissue all the way to the buccal. And as you saw, the frenal attachment was too high. That has to be corrected. And that is the solution for such a complicated scenario. In just a matter of 5 minutes, we were able to solve the problem. Of course, we have to see how the patient will respond to that after 3 months of soft tissue healing. But in my mind, I have a plan and I have steps to follow that plan to solve that problem. And I have the equipment to do that procedure. I hope this session was beneficial, and we did a real case which actually came, and we're trying to show the importance of following the steps, and we are trying to guide you how the process of solving complications can help you in identifying the solution and predicting the problem earlier.